Okay, so we're going to be talking about short stature. Okay, so short stature is defined as height which is less than the second centile. So you need to be able to understand a growth chart for you to understand where the second centile is. Let me find it here. Second centile. Can you see that? And so being the second centile, that's going to affect about 1 in 50 individuals. So of these 1 in 50 individuals, most of them will have a normal reason for being of a short stature, i.e. having short parents. However, the further away you are below the centiles, the more likely there is a pathological course. So if you deviate further away, then you're going to get more worried. So the most common course of short stature is familial, as I just mentioned before, which allows for essentially the child to reach kind of the mid-parental height on the growth chart if they're a short parents, but there's nothing to worry about there. And then we have constitutional delay in puberty or growth, and this is actually a variation of normal growth. So basically the growth in childhood will be at the lower limits of normal, and there'll be short stature in the teenage years due to a delayed onset of puberty or growth, really. And basically the onset of secondary sexual development will also be delayed. However, a silver lining to the cloud is that the final height will be normal. So it's just a delay rather than a huge impact. And then you can get kind of small for gestational age / extreme prematurity. And so a small percentage of these individuals actually remain small, i.e. they don't catch up. And another cause for short stature are chromosomal disorders / syndromes. So you've got disorders such as Downs, trisomy 21, and Turner 45X. I thought I had a good picture of this, actually. I do. So this is a child with Downs, and this is a child with Turner syndrome. You can see the characteristic webbed neck, slanted eyes for Down syndromes, prominent epicanthal folds, protruding tongue, etc., etc. You have heart problems as well. Okay, and so other chromosomal disorders which you also are looking out for are Noonan syndrome, which has been dubbed the male Turner syndrome because it has a similar appearance but in males. And that can be caused by a number of several mutations, not any specific ones. And Russell-Silver syndrome, which can affect chromosome 7 or 11. And then we have our nutritional / chronic illness related causes of short stature. And this is actually a common cause of short stature, to be honest. And these children are usually also underweight. So, i.e. the weight equals to the same centile as the height, or is of a lower centile of the height. In comparison to the height, I mean. So nutritional problems can arise from insufficient food, restricted diet, poor appetites, which can occur with chronic illnesses and other causes. And also some of the chronic illnesses which can lead to short stature are as described in this diagram, and I've mentioned that they're kind of all the C's. So you can get celiac disease, Crohn's, chronic kidney disease, cystic fibrosis, congenital heart disease. Now, just to mention, with cystic fibrosis and congenital heart disease, a factor which contributes to the shortness is that you've got increased work of breathing there, so your energy is going into that. With cystic fibrosis, there's also increased amount of infections and also malabsorption, as you will get in celiac disease and Crohn's as well. So another cause of short stature, endocrine causes. So you can get hypothyroidism, which can, but in the case of hypothyroidism, it can show catch-up growth if treated. However, the final height may still be limited. And then you can get growth hormone deficiency. So the pituitary may possibly be affected in growth hormone deficiency, depending on the underlying cause. And then you can get steroid excess causes, i.e. our Cushing's disease, or iatrogenic causes whereby excess steroids have been administered. And then finally, so all of those have been kind of proportionate causes of short stature. We've got our disproportionate causes of short stature, i.e. disproportionate meaning you've got kind of abnormal body proportions. So there are, so it's quite rare to get this, to be honest, and it may be caused by skeletal dysplasia. So I have got a summary of the courses here. So if you want to pause the video, please do. Let me get it all in. Is it all in? Hopefully you can see that. Okay, so what do we do in terms of diagnosis? So the most important thing in a diagnosis is plotting the heights and weights over a period of time as a growth chart, and this usually gives us a good picture of the course without a need for investigations. However, a few investigations may be indicated for you to narrow down your suspicions. So if you're suspecting constitutional delay or perhaps hypothyroidism or growth hormone deficiency, what can you possibly do? You may want to take a hand x-ray in order to determine the bone age, and this can often be decreased in constitutional delay and decreased markedly in the other two. Okay, so what about if you want to find out about the anemia in celiac and Crohn's disease? You can do a full blood count. What about just trying to investigate just celiac disease itself? You can do anti-TTG or anti-EMA. What about Crohn's? You can often levels of CRP and ESR are raised. How are you going to be investigating chronic kidney disease as a course? You might want to do your creatinine and your electrolytes, see what's going on with those. How about just in general, renal and bone disorders? So you want to check out your calcium phosphate and your alkaline phosphatase. How are you going to investigate primary hypothyroidism? It's in the name. You want to check your thyroid stimulating hormone, because in hypothyroidism, the levels of TSH are going to be high. How are you going to find out about chromosomal disorders, e.g. Turner syndrome, karyotype? as you can see here, there's 1X, 45X Turner syndrome. But obviously there are other chromosomal abnormalities that you might want to carry type 4AG Downs. Although that'll be quite obvious clinically as well. Growth hormone deficiency, how are we going to do that? We can do growth hormone provocation tests. So this can often use, insulin or glucose, I believe. And another way of testing for growth hormone disorders, IGF-1. And what about investigating Cushing syndrome? 9 AM cortisol and also your dexamethasone suppression test. And finally, how would you investigate a craniopharyngioma or intracranial tumour? MRI. Okay, cool.